Okay. Hello. I'm Linda Schaven. I'm a member of the FESCA board, and we're now going to talk about. Sorry, my glasses. And now we're going to talk about how to handle upper-lower intestinal tract problems by Professor Khannan. He don't have a lot of time, so I'm going to introduce him very short. He's professor of medicine and director of University of Michigan skleroderma program. And beside me is Professor Celiak from Hungary.
Yeah, I am one of the founders of the USTAR, and I am the head of the Department of Clinical Immunology and Rheumatology in Pécs in southwestern Hungary, and I have a history of working with skleroderma patients of 35 years.
Okay, Professor Käännös.
So good afternoon, everybody. Welcome to Bordeaux. How many of you know where Michigan is? About 20%. It's better than most of the people. It's a state near Chicago or Illinois, east of that. So I'm a rheumatologist, but I treat about 3,000 patients a year with skleroderma. And I will talk about the gut involvement in this disease. There are two handouts if you go to Skleroderma Foundation website that we have written. The first one talks about the gut involvement in skleroderma, and the second one is written with the patient, Linda Kaminsky, who's also a nutritionist, that talks about how to eat well with skleroderma. So we'll talk about anatomy. We'll make you some doctors here today. Let's talk a little bit about anatomy. And when you think about the gut or digestive system, you think about these things: your food pipe, your mouth, your food pipe, stomach, small and large bowel, and your liver. And if I asked you, we don't have enough time, I could ask you which side of the body is the stomach, right or left? Let's hear who says what. Who said right? Well, you're absolutely wrong. It's on the left side of your. But you have the food pipe, you have the stomach, this is your liver, this is your gallbladder, the small and the large bowel. A lot of people are here because many of you have gut involvement or GI involvement due to your skleroderma or gastrointestinal involvement due to your skleroderma. And many people have symptoms, and we will talk about those symptoms. Here's a survey I did with the Skleroderma Foundation many years ago in US, and these are the symptoms patients complained about: heartburn, difficulty swallowing, bloating, diarrhea, constipation, and fecal incontinence. 1 in 3 patients did not have control over their bowel, which is quite a bit, but doctors do not ask that question. So 1 in 3 people. The function of the gut, apart from enjoying wine out here and eating good French food, is to make sure that the food is pushed down, you absorb the nutrients, through a well-orchestrated motion of the gut muscle called peristalsis. In skleroderma, the main event is the weakening of that muscle. The scarring, what's happening in your hands, what's happening on your face, what's happening in your lungs, is also happening in your food pipe. It's top down. It starts in your mouth, your food pipe, stomach, and it goes down slowly. And it can cause dysmotility, and we will talk about that. The first thing we will talk about is mouth involvement. I'm sure there are more lectures that will be given, but dry mouth, dry eyes is a big issue in people with skleroderma. We really don't have a lot of treatments, to be honest. We can give you some of the medications, pilocarpine, but the key part is you need to see a dentist who can see pediatric patients, who can see children, so they have instruments they can go back in the back of your mouth. You have to make sure you get dental cleaning on regular basis and continue to drink water on regular basis. These are the different commercial dry mouth medications that are available that you can put in your mouth while you're sitting here, so there's enough saliva that the mouth can produce. And if you want to make a home remedy, you can try 1/4 teaspoon of salt, baking soda, and water and mix it and keep on sipping it. And these are the different medications that are at least available in US, and I'm sure they are available here. They are xylitol-containing products. They have very little calories, so you can feel free to have it, but they keep your mouth moist and prevent cavities and other aspects. One of the key things your dentist should be looking at is whether you are having damage because of the heartburn. How many of you have acid reflux? About 30% of you, not a lot. Acid reflux, and maybe a lot of you don't know that you have acid reflux, but acid reflux can at night jar into your teeth. It can really destroy the enamel of your teeth. And here's one of my patients. When you look in the back of the enamel has been destroyed because of the heartburn. So what is heartburn? Heartburn is same as reflux. It's same as acid coming down the throat, up the tube. And liquid content of the stomach regurgitates, comes back into your food pipe, into your mouth because of weakening of the gut muscle and also weakening of this junction. When you eat something at night or in the morning, the junction opens up one way, the food goes in and it closes back. So if you eat at 10 o'clock a pizza out here and you go to bed at 11 o'clock, you might be fine, but when you have scleroderma, this is wide open. This is flattering. So as soon as you lay back, that food, the pizza comes back into your mouth. And that's what's happening. The food pipe is not working very well, not contracting very well, but the junction is not functioning very well. The valve is broken. So anytime you do something and don't take small meals and take enough time for the food to digest, this may happen. Heartburn is not the only symptom. I have patients who come, they say, my voice is changing. They come and say, I'm having recurrent chest pain. I have gone to the ER, and they have told me it is acid reflux. They get sores in the mouth. They have change in their voice. They have difficulty swallowing. They have chronic cough. One of the biggest reasons if you are waking up at night, coughing, may be silent heartburn that you are not aware of. And here's one of the patients where the food pipe, this is an endoscopy, the food pipe is showing a lot of inflammation in the gut. It's very important to treat the heartburn to help with your symptoms, but also a lot of that acid can go into your lungs and cause inflammation and lung fibrosis. We know that lung fibrosis is common in people with scleroderma. Irrespective whether you have been diagnosed with lung fibrosis or not, it's good to have management to make sure you're not aspirating. So if you take one lesson away, just one, this is what everybody should be doing. You should be sleeping elevated. That's the only take-home message from my lecture. One, you should be sleeping elevated. You can do that by buying a wedge pillow, or you can do that by buying blocks and raising the head side of the bed. There's nothing you can do about the food pipe not working. There's nothing much you can do about the valve not working. Every time you lie back, the gravity brings the food back into your food pipe. So if you sleep at an angle, the gravity keeps the food down. And that will prevent you from aspirating your stomach contents into your food pipe. Do not try to not eat late. So you can't have any dinner after 6 o'clock today, okay? I'm just kidding. You can and have frequent small meals and try to eat small meals throughout the day. Or people just got the joke. Okay, that's good. And you know, if you have, you can buy these adjustable beds where you know your husband can or your wife can sleep straight and you can sleep at an angle if need be. There are medications that we can give, and I have to tell you, those medications are effective, but they have a lot of side effects. So therefore, the non-pharmacological management, the management that doesn't require taking medications, is probably the most effective. So here are some of them to minimize chocolate. I can't be in France and say, do not eat chocolate. That would be wrong. But you can minimize chocolate, and you can take certain medications, such as any of these. These are medications that inhibit the acid production in the stomach, okay? Prevacid, Prilosec, omeprazole, lansoprazole, Protonix, Nexium, all these medications are available throughout the world. One thing I want to highlight that these medications are used 2 to 4 times the dose than used in people who do not have scleroderma. So we tend to use a much higher dose to calm down and suppress that acid reflux. But there are side effects of proton pump inhibitors. People can develop diarrhea, they could have low bone density or osteoporosis, dementia, chronic kidney disease. But this data doesn't come from patients with scleroderma. This data come from large administrative databases. You go to a French registry here, you go to a US registry, and everybody who was taking proton pump inhibitor may have this issue. But this is a real risk, small but real risk. So therefore, if you can manage your heartburn by sleeping at an angle, by eating short meals, by making sure you give enough time for the body to digest, that's probably the most effective way of managing it. I want to highlight, I don't want to scare you here, but I want to highlight that there can be a precancerous lesion. Some of the patients come and they say, we don't want to take any medication. We can live with the heartburn. That is fine, but over time, if you keep on pouring acid, think about it, I give you an acid and you keep on pouring every day on your hand. You start to get a burn, the burn will start to erode, and the erosion may turn cancerous, and that's what's called Barrett's esophagus that can be seen in about 10 to 13% of patients with scleroderma. Again, what you can do, effective management, see a good gastroenterologist and get regular endoscopy to be screened for that. I'm going to move from food pipe to the left side of the body, the stomach. The main issue in stomach is the same as food pipe, low contractility. The stomach is not moving very well. So you go out today, you have nice meal, the food goes into the stomach and it's just sitting in the stomach. You're feeling bloated, you're feeling distended, you're feeling nauseated because the food is coming up, and you're not feeling very hungry the rest of the day. We can do a gastric emptying study. How many of you ever had a gastric emptying study? So not many had a gastric emptying study, and I don't think I have a slide, but what they do is they give you a radio labeled, oh, I have to change that, it's not radioactive, I'm sorry. It's radio labeled. Did you get that? No? Okay, that's okay. So it's a radio label, they give you peanut butter and jelly, and they make you eat. It takes about 2 hours, if you don't have scleroderma, to food to get out of the stomach. In people with scleroderma, it may sit there for 4 to 8 hours. Okay, it comes late, huh? Okay. And the treatment are one of these medications. These medications are agents that increase the motility of the gut. It tries to push the food from the stomach into the small bowel. And all these medications are available, and they need to be given by an experienced gastroenterologist or a rheumatologist. I'm just keeping an eye on the time here. People who have early scleroderma might come one day and say, we are feeling very weak. We are feeling very drained. We are fatigued. It could be that scleroderma is active. It could be that your body is getting used to it. But it could be that you have watermelon stomach. Has people heard about this term, watermelon stomach? How many had it? One? So about 10 or 12 here had watermelon stomach. How many of you have telangiectasias on your face? A lot more. Telangiectasias is a mirror of what's happening in your stomach. And when you look at this picture, it looks like outside of a watermelon. And that's why it's called watermelon stomach. It can bleed intermittently. It can bleed slowly. You might see black stools, black tarry stools when you will go to the bathroom. And you're slowly bleeding. And you're getting more and more tired because you do not have enough hemoglobin. And what we tell our gastroenterologists is to go and burn those areas. So there's really no treatment except for burning all the areas that have watermelon stomach, and you might need multiple treatments. Fortunately, it's rare, but it's one of the main causes if you are anemic iron deficiency anemia early on in the scleroderma. It's very important to be educated because a lot of doctors are not educated about that. So when you are more educated, you go to your doctors, you can tell them, did you look for watermelon stomach? And they would know what to do at that time. The role of the small bowel is the part of the gut that absorbs nutrients. And again, lack of muscle tone can cause stagnation of the food, can have the bacteria that we have in the large bowel come to the small bowel. And when bacteria comes to the small bowel, it starts to cause a lot of distension, bloating, and weight loss. And that's called bacterial overgrowth syndrome. In layperson term, the bacteria are competing for your food. The bacteria wants your nutrition, and it's compete and causing severe bloating distension. It's probably the most common cause of weight loss. So if you're distended, you're bloated, you're having diarrhea all the time, you're losing weight, that's probably the reason that is happening. And it can cause malabsorption. So people who have bacterial overgrowth, it can interfere from absorbing the nutrients, the vitamins, the minerals that you need. And the treatment is giving antibiotics to calm down that bacteria to reduce the bloating and distension. Again, there are multiple antibiotics that are available that we can give. And if you have bacterial overgrowth, and if you get an antibiotic, it improves quite soon. It is very effective early on. However, some patients need antibiotic for a long, long term. Going to the colon or the large bowel, its main function is to absorb water and salt, and this can help in formation of the stool. So people always talk about constipation. What is constipation? This is a medical definition of constipation. And the biggest three parts of the constipation are less bowel, but hard or lumpy stool, incomplete evacuation, and you keep on straining. That's the definition of constipation. The most common cause of constipation is that people are not taking enough roughage, not drinking enough water. In scleroderma, that's not the main reason. In scleroderma, the gut is not moving very well, the water is getting absorbed, and you are getting hard and lumpy stool that's making you constipated. Here are the medications that you can take on regular basis. You cannot treat constipation when you are already constipated. You should take medications on regular basis so you do not get constipated, and these are the different medications that are available. I'm going to go to the final part of my talk, which is fecal incontinence. It's very, very important, and I see a lot of my patients who have fecal incontinence but never tell me. They are shy. I encourage you to talk to your doctors about fecal incontinence. We can help you by giving biofeedback therapy. We can help you by giving some bulking agents, and now we have treatment where they can put a small pacemaker in the tailbone, near the tailbone. It's as thin as a credit card, and it can be used to control the amount of incontinence episodes that you are having. I know Dr. Denton, who's in UK, does it. We do it in US. I don't know whether Dr. Hachula, Dr. Eleanor, and Mouton do it in France, but I'm sure it's also available out here. And then if you want to look for your GI involvement, you want to be aware of it, we developed a questionnaire that's now translated in 40 different languages, looking at the different aspects of your GI involvement and how it impacts your emotions and how it impacts your social well-being. So I will conclude by saying it was a quick talk, that scleroderma gut involvement is very common. It has a lot of symptoms. It can impact quality of life. A few messages to take. You have to take control of the gut involvement. There are no magical medications we have right now. The non-pharmacologic management, sleeping at an angle, taking small meals, making sure you give your body enough time to digest, making sure that when you have symptoms of distension, bloating, you tell your doctors. Making sure that you stick with the medications that we are prescribing is an effective way to manage and treat this disease. Thank you very much.
Thank you, Professor Khannan. We have time for a couple of questions. Has anybody got a question about this? Over there, at the back.
Oh, I'm okay. Oh.
Can I? I have problems with diarrhea during a lot of years, and the doctors always says that it was a symptom of skleroderma. A year ago, I was diagnosed with Crohn's disease, and I would like to hear about the relation. Thank you.
So thank you for the question. Does everybody know what Crohn's disease is? So it's another autoimmune disease that can affect your gut or your bowel. It's called inflammatory bowel disease. And if you have an autoimmune disease such as skleroderma, you are at a somewhat increased risk of having another autoimmune disease such as inflammatory bowel disease, primary biliary cirrhosis. I don't think the relationship is that big, but we do see sometimes, unfortunately, patients, and I have a few patients who both have inflammatory bowel disease and scleroderma. I'm happy that they were able to diagnose it because there are effective management for that. Dr. Laszlo, do you have any comments?
No, I completely agree with that, that it is very important that there are many other autoimmune diseases which usually often coexist with systemic scleroderma, and you need to have a clear diagnosis of all these disorders. Otherwise, you cannot find a good treatment.
In bacterial overgrowth, in a patient who responds quickly to antibiotics, how long of a course of antibiotics do you typically recommend, firstly? And also wondering, do you believe in rotating different antibiotics with the next time it comes up, or keeping with the same that was effective previously?
Thank you for the question. Does everybody know what bacterial overgrowth is? How many of you ever had bacterial overgrowth? So you can see as we are going down the gut, the prevalence or the number of people who have it goes lower. And that's what we see in scleroderma. It's much more common to have heartburn, and as you go down the gut, the number of people who suffer, fortunately, from complications go down. Bacterial overgrowth, as I talked about, is the bacteria in the large bowel who crawl into your small bowel. Easiest way to make a comparison is competing with your food. The treatment are antibiotics. The antibiotics are usually given for 2 weeks, and we see how you respond. If you have bacterial overgrowth, the response can be quite impressive early on. But there's nothing we are doing for the gut. The gut is still slow and sluggish. And after you clean the antibiotic, complete the antibiotic, the bacteria gets cleaned, but in the next 2-3 weeks, they start to crawl back up. So sometimes patient, to answer your question, may require antibiotic on as needed basis if it's not severe. What we do is we give it every 2 weeks, every 3 to 4 months, every 3 weeks. It depends how severe symptoms are. If the symptoms are quite severe, some patients require continuous antibiotics. Now the issue with continuous antibiotic is what? You develop resistance to it. So what the doctors do is they rotate. They give you one time one antibiotic for a month, and then switch to a second one, switch back to first one, switch back to second one. So that is quite common, but fortunately, many patients do not require continuous antibiotic. It's an intermittent antibiotic. There are patients who take probiotics, and they're strong believer of probiotics. There's not a lot of data on probiotics. You have to be aware that probiotics are live bacteria. It's okay to take probiotics, but if you're getting cytoxin or chemotherapy, there have been some cases very rarely associated with bacteria getting into your bloodstream and causing problems. So be careful if you take probiotics that you're not taking a lot of immunosuppressive therapy.
Okay, I think due to the time we can take one more question.
Yes. depuis plusieurs années, je prends de l'inexium et j'ai un problème au niveau de l'estomac, c'est-à-dire que j'ai une multitude de polypes. Et ma gastro-entérologue m'a dit qu'on ne pouvait rien faire. Merci.
Thank you for the question. The question is that she has taken Nexium, which is a proton pump inhibitor, for many, many years, and she has polyps in her stomach. And first, I think the question is, what is the relationship? And the gastroenterologist told her they can't do anything about it. So that's one of the polyps in the stomach can occur if you have taken long-term proton pump inhibitors, and I showed you some of the side effects. The gastroenterologist probably does a scope so often, every year, every 2 years, and they probably do a biopsy to make sure that they are not cancerous. If they're not cancerous, the gastroenterologist just leave them alone and keep a close eye on them. And it's important to continue to get the endoscopy from them and keep a close eye.
Yes? Oh, the last question.
Do you have anything to say about fructose malabsorption and FODMAP diets? I sometimes think I could fall into that, and I can't digest nuts very well and different things.
So the question is, there are different kind of malabsorptions that can happen, and the question is regarding fructose. If you live in US, there's fructose everywhere, from Coke to canned sugar to meat what you eat. And there's something called FODMAP diet. So when you feel a lot of distension, bloating, you can take food that is low in oligosaccharides. What it means in English is that they're very high in sugars. So if you decrease the amount of sugars you're taking, it sometimes helps with the distension, bloating. I think before you take FODMAP diet, you should make sure you can do a breath test with fructose and see whether you are intolerant to that. So in our population, we do lactulose, glucose, and fructose breath test. If you are intolerant to that, then the nutritionist can develop a diet plan that can take away the fructose. I think that's probably a better way to do it than to self-diagnose and say, this is likely what's happening because I'm reacting to it. But if you are have malabsorption to it, that's a good way to do it.
Okay, only one very short comment that it is clear that you need a good rheumatologist who is following up your problems for decades. And also if you have gastrointestinal problems, you need a well-trained gastroenterologist as well, because these symptoms are highly variable, and you need experts who can help how to treat it efficiently.
Okay, thank you for your attention. Professor Käännös is running because he has to go to another meeting. And thank you, Professor Cesar.